Hi, good evening, everybody. My name is Ellen Baca, and I'm the Lehigh Valley Coordinator for the Epilepsy Foundation, Eastern Pennsylvania. I'm glad that I see a number of new faces. If you haven't already come up, introduce yourself to me. I'd love to meet you. I'd like to give a big thank you for the Lehigh Valley Health Network for hosting this event. This is the 8th time we've had it here already. The hospital does a really wonderful job of helping us plan this event, from the AV staff to housekeeping, to all the volunteers from Lehigh Neurology, to catering. The food was provided by them this evening, so we couldn't ask for nicer accommodations, and we really thank them for that. A big thank you to my sister-in-law, Sharon, who is the program coordinator for the Epilepsy Center here at Lehigh Neurology. She's not here this evening, but she does so much and responsible for making events like these run so smoothly. So I'd like to thank her for that. Today is March 26th, which is Global Epilepsy Awareness Month. I see a number of you wearing purple, so it's not a new concept to people. That's why I have this purple scarf on. I'd like to thank Lundbeck and Upshur Smith for their educational grants so that we can continue to offer free educational programs like this one. And thanks to all our vendors. If you haven't been next door, we have food and vendors over there. I'd like to thank Canine Partners for Life, Cyberonics, Lundbeck, Synovian, Supernus, UCB Pharma, and Upshur Smith. So quite a number are represented here tonight. So you'll find their tables next door, as I said. So those of you that aren't familiar with the Epilepsy Foundation, Eastern Pennsylvania, and what we do here, our goal is to provide education, support, and advocacy to you and your families, people that are diagnosed with epilepsy here in the 18 counties of Eastern Pennsylvania. Some of the things we do Project School Alert, where we go out to schools with parents and figure out ways for a child to get the best educational experience. We'll help with that. We educate teachers and administrative personnel about how to recognize seizures, first aid for seizures. So we do a lot of that. We have educational programs for any part of the public. We will go out to businesses, schools, like I said, nurses, government agencies. We have a program specifically for police officers and first responders. So anybody who's willing to hear about epilepsy, we're here to talk about it and spread awareness, which of course we all know that that's sorely needed, more education about it. We also do consultation for people, like maybe you're looking for a doctor or some legal counsel, or maybe a discount on prescription drugs, or maybe you're having trouble getting medical insurance. We're here for that as well. We understand the diverse issues that you confront on a daily basis, and we're here to help you. We also have support groups. Every second Thursday of the month, we have it right here at the Cassage Pavilion. We also have many other support groups throughout Eastern Pennsylvania, and there's actually on our resource table, there's a list of all the different support groups. So you might not be from Allentown. You might be a little bit farther away. You can see where we have our support groups. They're really a wonderful way to share emotional support and gain information. A lot of times we'll have speakers that come out and talk about certain issues that confront you with your diagnosis. So we have that. And of course we have these educational conferences every year, and we have other ones as well. We try to put it around this date because, like I said, it's Global Epilepsy Awareness Month. So, so we try to have it on or around March 26th. We also have something called Camp Achieve, which is a week-long summer camp for kids that are between the ages of 8 and 17. It's a great opportunity for them to feel a little independent and go on a week camp. It's supervised by medical personnel. It's a wonderful program. What you should have with you tonight, you have an evaluation form in probably your booklet. Please, we love your input. We pore over these because we want to improve our programs every year, so your input is really invaluable. For example, sometimes we wonder if we should, if it's time to have a Saturday conference, and that's a question on here. So whatever you can, if you can fill that out and hand it in at the end of the evening, we'd really appreciate it. You also probably, you should have this, which is a resource guide. And let's see, in the beginning of it, first section, it has a lot to do with seizure self-care, and just topics of interest, memory problems, what to do when you're going to see your doctor, how to document seizures. And then at the end, you'll find additional resources right here in the Lehigh Valley that you might find interesting. Also handed out were PowerPoint presentations of the two speakers tonight. I'm really excited about those speakers. And the last thing you may or may not have gotten is a postcard for an upcoming walk called the High Walk Mark for a Healthy Community. So they're out on the desks out there. That's another opportunity that will be talked about in a minute. So without further ado, I'd like to introduce our Executive Director for the Foundation, Allison McCartan. Thank you.
Thank you, Alan, and thank you for all the work you do for people with epilepsy here in the Lehigh Valley. I also wanted to thank all of the staff here at the Lehigh Valley Health Network, including Sharon and Donna and Chris that's doing our technology, and Gary that I just met. It really is a wonderful partnership that the foundation can have with the Health Network, and we're so appreciative of everything that they do for the organization and to improve the lives of individuals with epilepsy. It truly is a partnership. As the foundation, we meet the non-medical needs of people with epilepsy, so we need those well-qualified physicians and nurse practitioners to help us with the medical needs of those individuals. So truly, we can't thank them enough tonight. So as an organization, we strive to improve the lives of individuals with epilepsy. And we do that through all of the programs that Ellen has talked about. So each year we serve about 15,000 individuals annually, and although that seems like a remarkable number, we always hear about the frustrations of our constituents or those living with epilepsy that don't think there's enough awareness happening in the community, within the general public, and even with their loved ones, of not truly understanding what it is an individual is going through living with a diagnosis of epilepsy. So the organization does work tirelessly to combat this issue. We utilize our social media pages. We meet with local elected officials to see who in their district is living with epilepsy, who we could potentially serve. And we also use our volunteers to help spread the word about what epilepsy is and what it is not. There's always more to be done. So tonight I just wanted to give you an example. One of our constituents, one of our support group members that is going out and making it his mission to create awareness about epilepsy. So the tech guy's here, I think. So let me see if I can do it without his help. Okay. It's only a really short 50-second video, and you're welcome to go and look more about Dan Doherty on the website that's listed. You can see it.
Living with epilepsy is very frustrating. You can't move up in the world like others can. My fellow Toastmaster, he said, find your voice, serve the world. And that's kind of like what I'm doing now. Find your voice and serve the world with awareness of epilepsy. Now I actually have a better understanding of who I am, to the point where I believe I have epilepsy for a reason. It's kind of like a gift in a way.
So as I said, if you want to learn more about Dan, you can go to that Health Central website, and the foundation has linked to him through our Facebook page and on our website. But
I was a little girl. My father.
I thought I did that right. I did it not.
It's a name that has stuck with.
Snuck back up on me. Sorry, gang. Okay, so you can practice that, but of course, when it goes live, you're still going to screw it up. Okay, so Dan Doherty is one of the foundation's volunteers. He truly makes every day Epilepsy Awareness Day. That's his vocational mission, to spread the word about the organization, about the cause, and what it is like to live every single day with active seizures. Dan goes out into the community. He speaks to religious organizations, the business community, and just local organizations that will hear him talk. So I know not all of us are public speakers and comfortable being out in the public, but I did want to encourage all of you to find a way that you can help spread awareness about epilepsy, because the foundation can't do it alone and Dan Doherty can't do it alone. We count on all of us to talk to our friends and our family to make our communities a more safe and comfortable and healthy environment for people living with epilepsy today and tomorrow and in the future. So Ellen mentioned today's Purple Day, it's internationally recognized. March 26th is Purple Day. And it was started just back in 2008, really recently, by a young girl before she was at the age of 10, and she wanted to know how many people supported her in her diagnosis of epilepsy. She knew nobody. So she says, well, if everybody could wear purple on one day, I'll see what a supportive community I live in, or I'll understand that epilepsy doesn't just affect me, it really affects so many others. So encourage your friends, encourage your family. If you're wearing purple today and you are on social media, use that hashtag Purple Day, or hashtag EFEPA, the foundation's information, so we can make this a more recognized disease. Not only do we try to create awareness on March 26th, but the entire month of November is dedicated to epilepsy awareness. So on the foundation's website, we have opportunities for you to plan fundraisers, to get involved in some of the educational programs that we're doing, or just as simply as passing out some literature in your local communities to your colleagues. Whatever level you're comfortable of doing, there are ways for you to get involved, and I would love to see your participation next November. Ellen also had mentioned that for the first time, the Epilepsy Foundation Eastern Pennsylvania is going to be involved and have a team at the Highmark Walk for Healthy Communities. It's going to be on May 30th. It's the main part of it is a 5K, but you could also do just a 1 mile fun walk. So we'll all be there. We would love your participation. And we've already had some really remarkable stories of someone just signing up, starting a team, and from that team of inviting friends and family, she learned that many other friends and family members had epilepsy or knew somebody with epilepsy. So it really got the story started. So that's one opportunity. And if you can't make that walk here, the foundation also does a walk in Chestnut Hill on June 20th. So that would be another opportunity that you absolutely see the entire community coming together, from doctors to pharmaceutical companies, to the foundation's volunteers and staff people. And it really is one of my favorite days of the year, because it is so tremendous to see 1,200 people banding together and actually celebrating people with epilepsy. We go through a lot of struggles day in and day out. So let's actually just have a day of fun and support one another. So that was my little spiel. I would like to introduce our first speaker here, Dr. Susan Ingram. She is a neuropsychologist for the Lehigh Valley Health Network. Dr. Ingram completed her master's degree in psychology and neuroscience at the University of Delaware and her doctorate degree at Georgia State University. She completed her neuropsychology internship at the Medical College of Pennsylvania and Hahnemann University Hospital in Philadelphia. Her clinical interests focus on how an individual's emotions, cognition, and behavior are affected by brain health and disease. Please join me in introducing Dr. Susan Ingram. You're comfortable with this facility, probably.
Yeah. Thank you. Hello, welcome. Thank you for having me. I am the neuropsychologist here, as was mentioned, and so I do a lot of work with people with epilepsy. I serve a lot of patients here who have had seizures and who are having seizures, and part of my job is to evaluate some of the cognitive problems that can go along sometimes with epilepsy, and some of the emotional symptoms that can happen as well. So I'm going to talk today mostly about the cognitive symptoms that happen, because it's something that's often, I think it's often sort of overlooked, and I think until recently it hasn't gotten a lot of attention in terms of treatment and thinking about those kinds of effects. And so I'd like to talk about that. I'm going to start first with just a little bit about the brain and how where the seizures are determines what kinds of cognitive symptoms people have, and also the long-term outcome, so that when people have seizures that affect certain areas of the brain, what kinds of symptoms are typical, and whether there's lasting consequences or not. And it varies a lot. So I'm going to start by talking a little bit about that, and then I'm going to focus more on memory, because memory is the thing that I am asked about the most. And people usually come and see me when they're having trouble with memory more than any other kind of cognitive problem, even more than attention. So I'm going to focus in a little bit more on that. And at the back of the handouts that you have of my presentation are some memory strategies, some memory tips and things that can help with different kinds of memory problems. So let me see here. So I just click okay. Oh, good. Okay. So before we start, I just want to say that cognitive impairment, the estimates on how many people that affect really varies a lot. And it varies with location, it varies with lots of different features of the seizures, but the recent estimates that I found were anywhere from 20 to 50% of people who have poorly controlled epilepsy or repeated seizures, or seizures that aren't very well treated with medications. Sometimes medications don't work as well as we would hope. So anywhere from 20 to 50%, and that's a large number of people, that could be struggling with various cognitive problems. Let's see. So just to get started, so that we're kind of all on the same page, the brain's kind of the seat of all of our thoughts and feelings. So when I talk about cognition, I'm talking about the thoughts. So things like memory and attention and problem solving and decision making and making judgments and planning and all of those kinds of thinking things that you do. And then emotions, that's our feelings. That's, things like our mood, anxiety, some of our personality and motivation, and some of those feelings, okay? And of course, we can't really talk about seizures without talking about the brain. So, the brain is the thing that kind of controls what we see, what we do, who we are. It's kind of the essence of all of us. And it's wonderful, but it's also, unfortunately, the source of seizures. So I want you to think for a minute about the brain as, as an organ of communication. So it's the purpose, at least in the sense that we're talking about today, is a way to communicate what's going on in the world and making sense of that inside, in our brain, and kind of triggering or causing behaviors and thoughts and feelings and things like that. So, individual nerve cells have to communicate with each other. They take in information from the environment, so what you see and what you hear and what you smell and taste and all of that. all of that gets taken in and interpreted by the brain and communicated to different areas of the brain. And that triggers or causes some either emotion or a behavior, an action, a thought of some kind. So for any of you that have children or like babies, you see a picture of a baby, okay, and that's the thing that you see. And your first thought might be, okay, that's my child. Like your brain's interpreting that picture, and there's a recognition, and you think, oh, that's not just any baby, that's my baby. And what does that cause? Some feelings of maybe love, a warm feeling. There's feelings that happen because of that. And then there may also be actions that occur because of that. And it's all because of the interpretation of what you see and what the brain, how that kind of communicates and causes us to think and feel and do things. So communication, sometimes it works wonderfully, but sometimes it can go awry too. So some things, sometimes nerve cells malfunction. They communicate with cells they shouldn't communicate with. They don't talk to cells they should talk to. If you think about a garden hose, if it's punctured and there's injury to that, just like if there's injury in your brain, water's going to spray all over the place. And when people have seizures, you can imagine that the same sort of thing can happen, that something that should be working well in the brain kind of or malfunctions. Information spreads to areas of the brain and gets communicated to areas of the brain that it shouldn't. And depending on where all of that information spreads to, it can cause seizures of different kinds. So the brain is really, really good at most things, but when something like that happens, that's when we can see seizures. So seizures can affect people in different ways, and they can affect your cognition, your thinking, directly and indirectly, and they can affect your thinking directly because they may affect the structure of those cells or the function of those cells, and then indirectly just by affecting the quality of life that people have when they have seizures. There may be changes in how people cope, changes in work, or changes in the quality of life. And so coping with those changes, stress that happens because of an illness like that can also cause problems with thinking, because any kind of stress and anxiety and mood changes can affect thinking as well. So you can talk about seizures and the impact they have when they happen, and the impact that it has on the brain and on thinking in particular. And there's several things that are really important in deciding how a seizure is going to affect someone and affect their thinking. And the location is probably the most critical. Where the seizure happens is most important. But then there are other things like the seizure type, the severity. Some of those things have a big impact as well. I want to talk more about the location, because that's what you're going to notice, and that's what most people notice, is what happens outward, when you have an event like a seizure in the brain. And so I want to orient you to the brain a little bit. And if you think about, if you're looking at the side of this person here, this is what you're seeing. You're kind of looking like that. And different areas of the brain are kind of specialized for different functions. And this is a pretty simplified view, but I think you'll get my point from this. And the areas in the back of the brain are responsible for vision. So if a seizure happens back there, you might have visual changes, visual problems. That's the area that's responsible for making sense of things that you see, okay? Then there's on the opposite end, the front part, okay, when seizures happen up here, this is the area of the brain that's responsible more for attention and complex thinking and judgment and decisions and things like that. So, and even personality. So, if seizures occur up there, then you're going to see something very different than if they happen in the back. And then there's areas that control more movement and sensation and language and memory, and those are the places where if the seizures start there or spread, you're going to see symptoms that have to do with memory or sensation, tingling feelings, pain, fear. It could be anything depending on where the seizures are located. So kind of what I was saying before, in the temporal lobe, which is the most common place that at least adults have seizures, if you were to put your hand over your ear like this, that pretty much covers the temporal lobe in your inside. That's where your temporal lobe is, and that's the most common site for seizures. And that's also, unfortunately, the area of the brain that's responsible for memory. And that's why people with temporal lobe epilepsy tend to have more problems with memory than with other kinds of cognitive issues. The parts of the brain that process emotion are also very close to those areas, kind of underneath and part of the frontal area. So you might feel emotions, there might be fear, panic, sometimes even psychiatric symptoms can happen and sometimes are misdiagnosed as psychiatric problems instead of a seizure. That's rare, but that happens sometimes. Changes in the sense of smell. Auras, one thing that happens with auras is sometimes there can be a sense of smell, a funny smell that happens right before somebody has a seizure. And that's because maybe where the seizure starts or where the activity in the brain is spreading. Okay, so the symptoms that you get depend on where the seizure is, right? But also the long-term outcome, what happens when you have repeated seizures. And most people who have cognitive problems, they have recurrent seizures or seizures that aren't very well controlled, that aren't responsive to medications, or maybe they've had them for a long period of time. So those are the cases where there's a greater chance that there might be some cognitive problems. And so in thinking long-term, areas of that temporal lobe there are mostly involved in memory, in new learning, in, excuse me, transforming things that you learn that are new into those long-term memories. So, for example, if you've just learned, you've just learned how to get into a file on the computer and you finally figured it out, you know where it is on the internet, you found the site, you just figured out how to do it, and then you have a seizure. Chances are some of that information will be lost because there hasn't been a chance for that information to kind of solidify and be stored in the brain. So things that are learned right before a seizure may not be remembered. Things that are learned, and if the seizure's in the temporal lobe. I just did something to this. I touched this and it went wacky. Ellen, do you know, I touched this thing in my, oh, okay. It's back, yeah. I don't know what happened. So anyway, seizures in that area are going to cause problems with learning and consolidating memories and storing memories and remembering things later. So if you have a seizure while you're trying to learn something, if you have a seizure just after you've learned something, and even if if you have a seizure and then try to learn something new, that area of the brain, if that's where the seizure was, is going to have a lot of trouble functioning properly, and you'll get problems there. Then one of the other main areas is the language areas. That's another common site for seizures. And so if seizures occur in that area, kind of the intersection of several areas of the brain, and it's really common, you might have trouble with word finding. I see people a lot who come in, they just say, I'm having trouble with my memory. I can't remember things. I can't remember what I want to say. I can't remember words. And it's actually sometimes a problem in the language areas of the brain, in being able to, in finding the words that are associated with the ideas. It has to do with how language is kind of processed in the brain, and sometimes being able to express yourself clearly or get the word out that you're thinking in your head and that sort of thing. That has to do with these language areas. And then seizures up in the front of the brain, especially if they're recurrent, okay, those can cause problems with attention. Sometimes those can also cause problems with memory, because the attention is involved in so many other types of thinking. So for memory, you can't really make new memories without the attention to hold on to and focus on what you're trying to remember. So, anytime something affects the frontal lobes and attention, it's going to make everything else harder, but in particular memory as well. And also, the strategies we use to remember things, like organizational strategies, and, if we try to rhyme things, or we think about, categorizing things, like if we're trying to learn a shopping list and we think, okay, instead of thinking about 3 separate items, we need, 2 of one thing. We need 2 dairy products. We're categorizing things in our head. And those are all processes that this frontal area of the brain kind of does. So, those are the main areas where you'll see problems with cognitive functions. Sensation, pain, temperature changes, vision changes, those occur in other areas of the brain. But in terms of thinking, it's really in those main areas. And I want to say a few words, too, about emotions, because emotions are also, a lot of times you can have emotional reactions because of the seizure itself. That seizures, if they occur in certain parts of the temporal lobe or frontal lobe, can cause emotional feelings. In some cases, fear, panic. There can be, depression. Not depression. Depression is one of the most common kind of outcomes because of other problems within the brain. But depression is probably the most common of the emotional problems that kind of come along with it. If emotion is really common, up to 55% of people that have, poorly controlled seizures, where there's active seizures, a lot of the time, it's very common to have depression along with that. And anxiety as well. Up to a quarter of people with seizures also experience anxiety, fear, a sense of apprehension with their seizures, a fear of having another seizure and not knowing when that's going to happen. So there's direct changes to the brain, but there's also changes that happen that are that occur secondary to the seizures and learning to live with the seizure. So depression and anxiety are pretty common. You know, the good news is that a lot of the seizure medications can also help with some of those emotional symptoms. Yeah?
What do you mean when you say pain there under depression? It says pain, insomnia, and fatigue. Are you saying somebody could like just have random pain from a seizure?
Well, it depends on where the seizure is, yeah. So people, you know, can have, if seizures occur in different, like up on top, you know, in some of those top areas, those are areas that control things like sensation and pain, temperature, all the things that you kind of can sense, you know, with your hands. So sometimes seizures can cause those things, but depression, you know, can occur because of seizures, but it can also occur because of some of the pain that happens because of seizures. You know, it's interactive and it's kind of interrelated. Insomnia, fatigue, those are also things that can occur as well. Okay. So a couple words about medications, and the medications for epilepsy are really good for controlling seizures most of the time, but sometimes they also have side effects that affect thinking. So there's and the types of cognition that are affected most are things like attention and processing speed and reaction time. Those are the things that are probably affected most by any of the seizure medication. So it's always a delicate balance trying to find the right seizure medication that's not going to interfere with cognitive functioning too much. But, you know, like I said, the good news is that a lot of those seizure medications can help with mood and depression and those things. So you can get some other benefits from medications as well. They're also very dose dependent. So, how much they affect somebody's cognition is going to be dependent on how high the dose is. So the more you can lower the dose, the more that might be able to help if you're having problems with thinking and memory and, you know, slow processing and things like that. How many medications can affect your thinking as well. More is worse, so fewer the better. But it's always kind of a delicate balance. So all of this is nice to know, but but so what? So, you know, the goal is really to treat epilepsy as you know, not just the seizure, but all of the other stuff that goes along with it.
Yeah, going back to your medication.
Yeah.
Would like side effects kind of really affect you as well? Like,
Oh yeah.
For example, you know, like let's say a side effect is fatigue. Wouldn't the patient be really affected by all these side effects if you have like 3 or 4 different medications?
Yeah, and that's how they affect people mostly, because they slow down people. They're sedating sometimes, some of them, so it can slow down. It can cause fatigue. It can kind of slow movements. It can make people feel like it's more effortful to think, like it's just a little bit harder to, you know, and you just aren't as quick maybe. And those are all, you know, some of those side effects of medications. So there's always kind of this balance between trying to get the best seizure control with the least number of side effects.
And doesn't it also depend upon, for the patient, like what's right for them? Like if you drop it too low, I understand that it would really bring out your seizures, but if you bring it up too high, like skyrocket up too high, wouldn't it really make them not feel well?
Yeah,
Wouldn't
it can
just, like,
interfere.
Make them basically feel like just sleeping on the couch?
Yeah. So you know, that's something that the neurologists I work with always think about when they're using these medications, and different medications also affect people a little differently. So what affects you and what you may have some side effects from may not affect somebody else the same way. So, so there's always kind of this, you know, very individual kind of approach to how much and what kinds, and, you know, with the goal being the best seizure control, obviously, but with the least side effects. Yeah.
Yeah, thank you.
Uh-huh. The thing is, if you know about some, you know, if you know about some of the ways that seizures affect you, then it can help in thinking about what treatments. It may affect you and your doctor talk about a dose of medication that you're on, or the type of medication. It may be counseling can help. It may be cognitive rehab, or use of cognitive strategies. I mean, they've found that even cognitive rehab, which has been most often used like after a traumatic brain injury or something, you know, a lot of those strategies for helping people learn to remember better, learn to pay attention, you know, those strategies often help people with seizures as well. So, you know, we're seeing more and more research kind of looking at what kinds of cognitive rehab is helpful for what kinds of patients and what kinds of seizures. But, you know, if we can help identify some of the things going on, then it can also help with the treatment and finding ways to, you know, improve quality of life. So, so it's, I don't know how much time I have, but I think I'm almost done, and I didn't even talk about memory. Let's see. So let me, let me just say this, that if you think about memory can be thought of in a lot of different ways, okay? There's different kinds of memory. So there's memory for things that you hear, there's memory for things that you see. I mean, how many of you have had the experience where you recognize somebody's face, but you have no idea what their name is, but you've seen them, you know who they are, but you can't grab that name. So you may see something, you may be great at directions, you know, on the road and finding your way, but to tell someone the street names, forget it. So people have strengths in different areas, and memory, you know, there's different kinds of memory. There's memory for doing things like riding a bike, and that's completely different than other kinds of memories. There are memories for different smells, for different tastes, you know, for music. I mean, how many of you have heard a song and it instantly brings you back to something, you know, that, you know, a song or a time in your life when you heard that song before. So there's different kinds of memories and different ways that we can use, you know, those different types of memory to help when there's a problem in one particular area. So if somebody's having trouble learning something like, you know, if somebody's having trouble remembering conversations and things that are said to them, then one of the ways that we can help is to think about, well, how can we make that information more visual for the person? So they're not relying on their hearing and processing, but they can make something visual. Okay, if you think about all the ways you learned about things in school, you might have had diagrams, you have pictures, you might have had a flow sheet, in addition to the words, maps and drawings and all kinds of stuff. And it's all helpful because it helps you process the information in many ways, and it uses many different areas of the brain, and it doesn't rely on one particular area. You may be able to use different strategies and use different strengths that you have to be able to learn and remember things better as well.
I have a question.
Yeah.
Which handles more memory, the amygdala or the hippocampus?
The hippocampus. Yeah. There's a little structure inside the brain that it's kind of underneath. It's underneath the temporal lobe called the hippocampus, and that is the main area of the brain that kind of consolidates memories. So anything that you're holding in your attention and thinking about and you're trying to remember, if you repeat it, You know, if you diagram it, you rehearse it, you review it, that process helps strengthen all those connections in the hippocampus. And that's the main structure for new learning and memory. So if there's any damage there, if there's any damage in the structures or because of seizures, then it's going to disrupt that area and make it much harder to hang on to that information and use it later.
Is the amygdala emotion?
Amygdala is more involved in emotion, but the two are located very, very close to each other. So sometimes there's emotional memories that are kind of linked, okay? And they both can be involved in some kinds of memories. Yeah. So I think the handouts that I gave you, it talks about just some memory strategies. And I talk about strategies for improving input, which is getting the information in. It relies on attention, it relies on focusing and processing information and holding it for a brief period of time. And then there's also the part of memory where those things that you're holding in your head are consolidated, and that's where the hippocampus kind of comes in. And then there's retention of that information. You want to be able to retain it, hold on to it, grab it when you need it. And finally, the process of retrieving information when you need it. And that's what's really the remembering part of memory. So you have information stored in your brain that sometimes the difficulty is getting it when you need it. So it's kind of like the difference between if I were to ask you, what's the capital of Italy? How easy is it for you to recall the capital off the top of your head versus is the capital of Italy blank, blank, blank? So there are different ways people learn, different ways people remember and learn. You know, one of the reasons people come to see me is to have their memory evaluated and to see how they learn, how they remember things. And often I can give strategies and some helpful information about those areas of strength that you can use to compensate and use, you know, in your daily life. So the strategies and tips that I have for you kind of give you strategies to help in each of those areas. Getting information in, there's tips for how to kind of hold on to information and make them permanent, store them. And then there's tips for how to get them out when you need those memories, things that will help you retrieve information when you need it. And then a bunch of other things, I think, too, that are kind of related, memory strategies, mnemonic strategies, and things like that can be helpful. So I'll be hanging around here, and if you have some more questions after, I'm happy to answer.
Another quick question. You said about long-term effects.
Mm-hmm.
Say, what are the effects like 10 years? Do they even know if you have a seizure? What are the term effects, like, say, if you have a seizure year for 10, 15 years?
Mm-hmm.
Is there any study on what happens then? Do they have...
Yeah, I mean, in cases like that, that's when you may have seizures over a long period of time, but the number of seizures is low compared to somebody who has seizures every single day or many times a day. So for that situation where it's a seizure a year, the chances and the vulnerability there is much, much less. So the chances that there would be some permanent effects on memory or attention or anything else is much, much lower than for somebody who has even, you know, like a seizure a month or a couple of seizures a month, and that continues, and it's very hard to control that.
I just got one more question.
Yeah, sure.
Is there any way to prevent a seizure? Say if you can almost feel a seizure coming on. You're going to go to bed that night, you know you're going to have a seizure. Is there anything you can do that night to stop that or prevent that from happening?
That's a good question. I would think probably not. I don't know, but I'm going to leave that for the neurologist in the back for when she comes up, and maybe she can speak to that. Because I'm not sure. I mean, my guess would be no, that I think what happens, unless you take some medication, unless there's something that stops that electrical kind of landslide that happens where, that the seizure spreads in your brain. But, I'll let her address that. She can probably address that better than I can. Yes?
I have a loud voice.
Oh, well, it's recorded.
Oh, okay. I wanted to know if there are any other psychological disorders that often come as a result of epilepsy. I know depression and anxiety, but are there any other common ones aside from that?
There's been some report of things like bipolar illness or psychotic episodes. I mean, those can happen, but they're much, much rarer. The other thing that can happen sometimes with seizures and with other neurological illnesses is there can be what we call pseudo-seizures, where it feels just like a seizure. Something is happening. You're having changes that are just like a seizure, but there isn't the same electrical activity going on in the brain. It's different at a neural level. And they're called pseudo-seizures because they don't have that electrical activity, but people experience them just like seizures. And sometimes they're related to psychological issues that are happening, and that's mostly how they're treated now, to cope with those. And a lot of people who have seizures can sometimes have these pseudo-seizures when they have the experience, but not the electrical kind of correlate.
Now, can epilepsy heighten, like if someone already has started out with bipolar and then proceeds to get epilepsy, will that worsen the bipolar or the anxiety in any way?
I think it depends probably on what kind of seizures they are and where they are in the brain, and all the other things that we talked about. I mean, if the seizures are poorly controlled, if there aren't effective medications and that sort of thing, then the combination of those, the bipolar and seizures is not, that's not good. It's going to be very hard to treat that. But a lot of the epilepsy medicines are mood stabilizers, and in fact, they can help with some of the mood changes that happen with something like bipolar.
Thank you.
Yes.
That pseudo seizure.
Mm-hmm.
Is that where like you just slow down? The pseudo seizure, is that where you just kind of slow down and you just kind of, I can almost talk myself out of them, like I'm not going to have this right now. And then all of a sudden, everything comes back to normal.
Okay. It's more like you might have the same experience of having a seizure, and for some people it may be, there may be some speech problems, it may be some tremors or some shaking. You may have some of those same symptoms that happen during a seizure, but they just aren't sure of the cause because they can't link it to the underlying brain activity. They can, so they call it pseudo just because they're really not sure what the cause is, and it may be that there's psychological factors that kind of contribute to that feeling of having a seizure. Does that answer your question?
Yeah.
Okay. Yes.
I have right here.
Oh, okay.
I just want to ask you to clarify something you were talking about before.
I can't hear you. I'm sorry.
I'm sorry. I just wanted to ask you to clarify something you were talking about before regarding how the seizure outcome depends on location. And
Yeah.
So with the depression and anxiety, are they emotional responses based on where in the brain the seizures come from, or is it more because side effects of the medication, or a combination of the two?
Yes, both. It can happen because of where the seizures are, but the anxiety and depression, those can be secondary to the medications, okay? But it can also occur, because you're trying to cope with a chronic illness, that anything that changes your quality of life or, makes things difficult can affect your mood and how you sleep or, your attention at work or anything like that. So it can happen because of any of those mechanisms.
We have time for one more question.
Okay.
Hi, I'm newly diagnosed with this. Looking at the slide on the second page here, seizure impact on brain. Item number 3, I'm 72. That was the age of the onset. The seizure type is partial onset seizure. The medication I started on was Lamictal, which I had bad reactions, and so they put me on Keppra, which is working well. What can I expect from here? As I age, will I go on to the next step beyond partial onset seizure?
I think, well, partly it depends on the cause, and the cause can be for any number of reasons.
Mm-hmm.
If it's possible that the seizures can be well controlled, and that will be, you'll be, that won't worsen. That what you're experiencing now may be what you experience for a long time. But a lot depends on the type of seizure and the cause of the seizure. Sure.
Thank you.
Thank you, Sue. That was wonderful. Did you get through everything? Did you get through everything?
No, I got through
No.
like half, but that's
Aw.
okay. I wanted to talk more about memory and stuff, that stuff, but it's okay. I'll be around, so if people have questions.
We're just going to take a short 10-minute break. There's still food over there next door. Make sure you visit the puppies. They're really cute. And then we're going to, our next speaker is going to start at 7:15. So thank you. Well, I just need like maybe one of, I think I might have gotten one.
Yeah.
Hi, everybody. Ooh, wow. Don't forget the forms, the evaluation forms. And there's two sides to it. So like I said, it's really helpful for us so we can improve on our programs. And during the break, we also handed out the Highmark walk. We've already have 35 people coming out to walk. We'd love for you guys to join us. I promise it'll be a sunny day. I can't promise that, but I'm hoping it'll be a sunny day. So it'll be a lot of fun. So hopefully you can join us there. You saw the signs for this is recorded. We have a YouTube account, and we're going to put these lectures up on YouTube for those that couldn't make it this evening. They can actually watch it. So that's why I accosted some of you people with this. And I'm going to do that again when Dr. Palangio comes up to talk. So we're trying to save the questions till the end. So if we can do that, that'd be great. And I'll probably come around with this, because if I don't, then the recording will not pick up what you're saying at all. So that's why I'm doing this. All right, so I'm going to introduce Dr. Palangio. Dr. Kimberly Palangio is a neurologist for the Lawrenceville Neurology Center and is affiliated with the Princeton, New Jersey healthcare system. Dr. Palangio attended New York College of Osteopathic Medicine in Old Westbury, New York. She subsequently completed a neurology residency at the North Shore Long Island Jewish Health System, where she was chief resident of neurology. She also completed a fellowship in clinical neurophysiology at the University of Pittsburgh Medical Center. She's board certified in neurology, epilepsy, and clinical neurophysiology. Please join me in welcoming Dr. Palangio. Thank you.
And what do I hit? Just this?
Yep.
Okay. All right. Hi, everyone. Thanks for the introduction. I'm Dr. Kim Palangio. As she said, I work for Lawrenceville Neurology, Princeton Healthcare System. And when Ellen first asked me to give this talk and told me I was talking about the impact of epilepsy, it's a pretty hard topic to discuss. And while I was doing research on all of this, I started going on some patient blogs at the Epilepsy Foundation. Came across this a patient with this quote, which essentially said, "My doctors are very knowledgeable about epilepsy, but only people with epilepsy truly know the impact, on themselves." And it's very, very true, and it's hard to talk about it when you don't have epilepsy yourself. So what I decided was, most of the questions that were going on in the epilepsy blogs were because a lot of different, the lack of knowledge, and I was wondering, why they didn't have the power to ask their doctors about these things. They're desperate for answers on the Epilepsy Foundation website. So, I think that the strongest message I want to put out is, find a doctor that you can really talk to, discuss these things, because knowledge is power. The more you know, the better you're going to be able to handle your diagnosis. So I'm just going to go over a couple of those questions, a couple things that my patients ask me when they're first diagnosed with epilepsy. Okay, so some of this was already discussed in the last lecture, so I'm going to breeze over it pretty quickly. So a lot of times when people experience their first seizure, they aren't aware that they had a seizure. Only the people around them know that they've had a seizure, and they're left dumbstruck. What happened to me? What happened to my brain? What's going on when I have a seizure? So as what was already discussed, we have to know the basic brain physiology, what's going on in the brain. And our brain works through electricity. The basic cells of the brain, called neurons, communicate with each other through electrical conduction. If you want your arm to move, one nerve talks to another nerve, which talks to a muscle, and it makes your right arm move. And that's actually very well balanced in the brain for the most part. We have these beautiful circuits that are very well programmed, and generally there isn't a problem. Move on. And these beautiful oscillations in the brain create what we see as brain waves. And as you can see, this is what we see on an EEG in the brain of somebody who does not have epilepsy, these nice oscillation of brain electrical activity. So what happens when someone has a seizure disorder? Well, some of these neurons in the brain misfire unintentionally, erratically, and when a couple of them get together and synchronize, it causes a spark, an electrical spark in the brain, which then can spread to adjacent cells. And when that happens, we have unintentional actions, and that's what we call a seizure. And what was already discussed is that if this spark in the brain is in a given site, the seizure that will manifest is what is dedicated to that part of the brain. So, as was already discussed, if it's in the back part of your brain and you have this little spark, you're going to have hallucinations or abnormal visions. If it's in a motor part of your brain, you're going to twitch. If it's in a sensory part of your brain, you're going to feel things that other people can't see. And that's called a focal seizure. It stays right there. If this firing is in the entire part of the brain, we call that a generalized seizure. And this is what most people know, what you see on movies where, we have the grand mal seizures, the tonic-clonic seizures, even though there's other types of generalized epilepsy. That's the one that's known best. And the focal epilepsies, the ones that are in that tiny little part of the brain, can spread and become a generalized seizure. So after we know what's going on in the brain, we need to know what's going on. Is there a risk to having the seizure to my brain? And the risk is really based on what type of seizure you're having. So focal seizures, you can either have impairment of consciousness or you cannot have impairment of consciousness. The impairment of consciousness is really the dangerous part because that's when you start to have the accidental injuries, which really is the main danger to the focal seizures. If you're cooking on a stove and suddenly you have this focal seizure where you lose awareness and then you burn yourself, that's the trouble with that. And again, as I said, they can generalize and become the grand mal seizures. And then we think of the generalized seizures, they're either short or they're long seizures. So again, the short seizures, accidental injury, you can have these transient changes in your body's physiology, but they're not as big of a medical emergency as the prolonged seizures. Prolonged seizures, generalized seizures, is really where we start to become nervous. And these are the things we really try to prevent. And that's what we call status epilepticus. By definition, status epilepticus is a seizure that lasts more than 30 minutes, or a group of seizures that occur, a cluster, where you don't fully become aware in between. That's the technical. The realistic version is any seizure lasting more than 5 minutes, because the longer the seizure is, the harder it is to break. So we really start to treat aggressively after a 5-minute seizure. And what are the effects of status epilepticus in the brain? Okay, so prolonged seizures, and these are not short seizures, prolonged seizures, we start to see damage to the nerve cells themselves. In the hippocampus, which was spoken about earlier, in the thalamus, which is the relay center of the brain, and the basic meat, the neocortex of the brain. And we also start to experience something that we call epileptogenesis. So epileptogenesis is when you have a prolonged seizure, changes start to occur in the brain that make your brain more susceptible to have more seizures. So not only are you having the immediate damage, but you're creating changes in the brain that make you higher risk to have a seizure. So, again, the short seizures, we worry about them, but it's nothing compared to the prolonged seizures.
Our daughter has partial complex seizures, and she usually clusters like 18 within an hour. But between each of the seizures, she baseline it comes back to normal. So that's still the status of
No. No.
Do you mind repeating her question?
So her question was that she has a family member where they will have a cluster of seizures, but in between she becomes fully aware and back to herself. And is that considered status epilepticus? The answer is no, but of course you need to have a plan, where if that were to happen, a plan of action of what to do next. So what are the physiologic, we know what's going on in the brain during status epilepticus. Now what's happening to your body in status epilepticus versus a seizure? So during a seizure, your blood pressure will spike and then it will gradually come back down. Okay, and that's a very normal reaction. In status epilepticus, it's more dangerous because the blood pressure actually falls. Okay, and when the blood pressure falls too low, you start to have problems perfusing the brain. We can also have cardiac effects to status epilepticus. With seizures, it's very uncommon. Cardiac is heart. So it's very uncommon. Some seizures can cause a lowering of the heart rate, but that's rare. Again, the dangers with the status epilepticus. Other changes are acid-base balance, the oxygen in your blood, your body temperature can rise. Now, the bottom.
I'm sorry. I have a son with LGS. Okay. Now, his temperature at a good night is 20, 40 seizures. So when his temp goes up, it's because of seizures?
Are they prolonged seizures?
Yeah.
Probably.
Okay.
Yeah.
He has this unknown, not high fevers, but just
Rises in blood.
Yeah, it rises.
Yeah, could be.
Okay. All right.
Yeah. The bottom line to all of this is really not to scare anyone, but the most common reason for somebody with epilepsy to go into status epilepticus is missing medication. Okay, so it's I can't say it's completely preventable, but a large majority of these are preventable if you have a plan to ensure that you get your medications regularly. No missed doses, and try to take them at the same time every time. And that's the bottom line. You can have seizures. We can work on that with your doctor, but we really have to try to prevent the status epilepticus. Okay, so let's talk about the accidental injuries. So as you can see, the statistics, 2.6 per 1,000 deaths related to accidents. Most common are water, burns, or trauma. Now, I'm going to skip most of these numbers, but the bottom line is the last line here. There's a Canadian study that showed that 5% of all drowning was from seizures. Okay, it's not a big number. And 60% of those occurred in the bathtub. And this is why your doctor will go over with you seizure precautions. Okay, we generally recommend that you take a shower and you don't take a bath. And if that's the case, 60% of these are avoided. So, you know, there's a reason we're asking you to do these things, and there's comfort in that, actually. Now, this is the thing that everybody becomes afraid about, is the SUDEP. But that being said, if you look at where it is in the list of reasons that there is death in people with epilepsy, it's all the way down at number 4. Okay, the risk is with the status epilepticus and accidental injury. 2 things that we already mentioned. You know, we have control over, that we can work on ourselves and try to prevent. SUDEP, even though we don't have a lot of good information on how to prevent it, you know, the risk is there, but it's low. So SUDEP is unexplained death, usually in sleep. The person's otherwise healthy, engaging in normal activities, and it's not status. It's not status epilepticus. It's not a prolonged seizure. It's 0.9 to 2.3 in 1,000 deaths, and 10% of epilepsy-related deaths. Not 10% of people with epilepsy-related deaths. Okay, it's less common in children, more in young adults, and the cause really is still unclear. We have our theories. Some of it goes back to that lowering of the heart rate during a seizure, but we're really not entirely sure. Risk factors. Men with an onset of epilepsy less than 16 years of age, although it could happen, you know, in females as well. Polytherapy, which is multiple medications, which would point to a more uncontrolled epilepsy. And for whatever reason, people who have found to have had this SUDEP have been found on their belly. So we think belly sleeping may contribute. So how do I protect myself from these things, from injury during a seizure and status epilepticus? So teach people around you, teach family members what to do, first aid for seizures. Everything that you should need to know should be in the packet that Ellen's providing to you. There is some first aid in there. You know, just inform people around you. Again, don't skip medications, make your home seizure safe. Go around each room and say, okay, well, if I were to have a seizure in this room, is there anything that would hurt me? Is there anything I should change in this room? Again, there's more of this is in your packet, but again, you know, guard the fireplaces, fall-proof the house. And there's medications available for home emergencies. You know, rectal diazepam for kids, liquid Ativan for adults. Some of us will give those medications for if somebody has an aura or a couple of auras and they know they're going to have a seizure. Some of us will say, okay, we'll take, a Klonopin or some Ativan to prevent that. I know there was a question about that earlier. I don't know if that gentleman is still here, but. And what's reassuring is that now the EMTs have been trained to treat these seizures in the field when they get to your house, because we know that treating early helps to prevent status epilepticus. You break it early, that's good. They know what to do. They'll give you the Ativan in the field. And then there's new emerging devices for safety at home. I know that the dogs were here today, and that's great. Monitors, pillows. Okay, so I'm going to just go over some quotes I found on the Epilepsy website, all right, and try to answer some questions. I love this first quote. Epilepsy doesn't define you, and it shouldn't define your summer travel plans either. I agree, to blogger Lauren. So just some general tips for travel, and again, if you're going to travel, talk to your doctor, have them, maybe write a note that you can carry with you in case you need it. Please have enough medications for your trip. You don't want to end up in another country without your medications. Try to avoid red eyes. It's a pretty good idea to get travel insurance. If you have a vagal nerve stimulator, get a card or a letter again, and avoid the metal detectors. Wear a medical alert bracelet. Okay, epilepsy on sports. I am not going to pretend to be a sports expert, and I'm not going to pretend to know who this guy is, but it's up there for inspiration. Apparently, he's on the New York Jets. So this was another quote on the Epilepsy website. It's about a 14-year-old who has idiopathic seizures. He only had 2, and he's on the rowing team, wanted to continue the sport, but his coach was very nervous. And I think that this just speaks to the lack of awareness out in the community as to, what to do with people with seizures. We get this all the time. We need notes for coaches, for teachers. We really need to work on informing the community about what seizures really mean. And for yourself, can I play this sport? Is it going to make my seizures worse? So there are rare instances where exercise or sports can worsen someone's seizures. But most of the studies show that it does not. So there have been studies where people have, worn an EEG and exercised, and it actually shows that the number of sparks, the number of epileptiform discharges in the brain stays the same during the exercise, or actually goes down. So that's very reassuring. And then we wonder about, the head impact, the head injury, will that affect the seizures? So contact sports should, there's no proof that contact sports should be avoided based on the level of risk of the sport. So there's low level, medium level, high level, and each carry a certain time limit, and that's also in your packet. Low level sports, you need to be seizure free for a certain time period. High level sports, again, when thinking about mountain climbing or scuba diving, again, as a non-athletic person, I think twice about that myself. But, just talk to your doctor about it, and based on how well your epilepsy is controlled, your seizure type, you'll be able to work it out, I'm sure. And then again, just wear the standard equipment like everybody should. Concussion's a big thing now, too. So, okay. Seizures and pregnancy. So this is about a woman named Kathleen who wanted children but heard all these horrible things about medications. Carbamazepine causing, spina bifida, cleft palate, cerebral palsy, and she wants to do everything to make her family safe. So the main point here, if you're planning on having a family, is that the impact of seizures on a pregnancy is far worse than the impact of seizure medications on pregnancy. So if you have a seizure while you're pregnant, multiple seizures has been shown to lower the IQ in a child. There's a risk of small for gestational age, which means the baby's smaller. And this was done in women who weren't on seizure medications, okay? So just the seizures themselves. And the risk of maternal death is higher if your seizures are uncontrolled. So we urge you to not go off your medications if you're thinking of having a family. Talk to your doctor. Again, it's very important. Family planning, we can work on trying to get you at lowest risk possible. We don't know the best seizure medications, we know the good ones, but we do know the worst. like valproic acid. We know that that lowers IQ. And then we have categories that we go off of, category C being a little bit better for women in pregnancy, category D we try to avoid. And we try to get you down to one medication if possible, because we know the risk is higher on 2 or more medications. Again, family plan with your doctor. If you're seizure-free before the pregnancy, you're very likely to be seizure-free during the pregnancy, up to 80 to 90% actually. So again, very encouraging information. And we know, if you take a folic acid, your risk is lower. You may require more frequent drug level monitoring, because some of these medications go up and down with hormones. And try to get sleep after delivery. Haha. So the risk over time has improved, and I'm very positive about these things. Unfortunately, you go on these epilepsy blogs, and they're kind of scary. A lot of these people who go on the epilepsy blogs have had bad experiences, but we see the good stuff all the time. Majority of people have very healthy babies, and if you look at the risk of major congenital malformations in the 70s versus the 90s, there's much improvement, 19.5 down to 3.5%. That's huge. And why is that? Because we have more people on monotherapy, on one medication, and we have more people on folic acid. There's a study that showed the IQ in a 6-year-old who was born to a mother with epilepsy is 5.6 points higher when they're on folic acid. Okay. So good moms equal good moms, whether you have epilepsy or not. You just have to make some modifications, okay? You could still breastfeed. The AAN totally supports breastfeeding, quoting, no harmful effects. Do some of these medications enter breast milk? Yes, but it's been studied and we fully support breastfeeding. General tips for new moms and dads, carry with a sling. Change the baby on the floor. Don't bathe the child alone. If you're not going to take a bath because you have epilepsy, don't give your child a bath. Have an enclosed play area. A little bit about seizure medications. So this is probably one of the most common things I hear in somebody who's been newly diagnosed with epilepsy. I hear horrible stuff about these seizure medications. My seizures really aren't that bad. Why do I have to go on seizure medications? So it's one of the biggest changes somebody is going to face who's been diagnosed with epilepsy, going on medications. Sometimes these medicines are the first ones you're ever going to have to take on a regular basis. Everybody hears the side effects. Nobody hears the people who don't have the side effects. So people get very scared. It's one of the hardest things to accept. And understanding the rationale as to why the doctor is actually putting you on these medications is huge. And it's all about risk. And we have to understand that everyone's risk is different. Everybody's individualized. So we look to see, did something cause this seizure that we can prevent? Were you drinking too much and then you had a seizure? Don't drink. We're not going to put you on seizure medications. So if we can't find a reason, then we think twice about it. The first seizure, your risk is still relatively low. We might not put you on a medication. The second seizure, we choose to put you on a medication if we can't find a cause, because then your risk is about 70% to have a third. So the risk is very high. The risk is also high if you had a seizure and there is something we see in your brain, a stroke, a tumor. The risk of having another seizure is high. So after the first seizure with something in the brain, we generally choose to do that as well. There are limited circumstances where, we choose to live, without seizure medications. One is a benign epilepsy in childhood. Most kids do not need seizure medications. The other thing is, the Traffic Administration reported that it only takes 3 seconds of inattention to have a traffic accident. So even though these things are lasting, split seconds, you have to think, is that going to impair your ability to drive? Is it going to still impair your functional status as an individual? So the next thing is, okay, well, I have to be on medications. Well, how do you choose? There's so many and so many new ones coming out. After June's seizure, the doctor prescribed Depakote. Why Depakote? Why this dose? Is the generic okay? So part of that is based on your epilepsy type. focal, generalized, or specific epilepsy syndrome, your age, is it the first drug, is it the second drug you have to be on? And if you're looking these medications up, some are approved for monotherapy, meaning the first drug. We don't always use them that way, okay? Sometimes your best drug might not be the one that's FDA approved for monotherapy, and that's okay, you know, because these therapies are individualized. We try to do the ones that are FDA approved, but even the FDA says that the doctors need to prescribe these medications based on their best judgment. We also look at side effects, drug interactions, pregnancy potential, costs. What about brand versus generic? So this person was on Keppra for 11 years, seizure-free for 10 years, and now they want to switch from brand to generic. Is it the same thing? Probably not. Okay, so we know that the FDA has allowed significant differences between generic medications. A lot of this is based on the manufacturer. Sometimes your pharmacies will substitute manufacturers, and they have different compositions, and then that will lead to seizures. Cost is a huge issue. A lot of insurance companies are, you know, approving medications less and less, unfortunately. Again, we are starting to have ways around this. There are certain pharmacies that are now generic pharmacies that will provide the same manufacturer for each medication that, you know, for each time you refill your medication, and that reduces the big risk of generics. So we are trying to work around this you know, whole brand generic cost issue. What about side effects? I know this gentleman here was talking about side effects a little bit and the impact. So this is a gentleman who was in graduate school. He was on Zonegran, which we know does have some cognitive side effects. He's tired. He's having difficulties concentrating, difficulties studying. One of the most common complaints is with memory, thinking, concentration, which we already heard about. There's many other contributors, seizures themselves, which we already spoke about. Seen more at higher doses, seen more with multiple medications, but there's some that are still decent. There are some medications that have good cognitive profiles. We know them, okay? We know which medications are going to decrease your cognitive speed, have no impact on your cognitive speed. But again, everybody is different. Your Lamictal might not be your Lamictal. Your Keppra might not be your Keppra. You might have side effects that are very uncommon, but, you know, again, it's all about talking to your doctor. Same thing with mood, psychosis. We know what generally happens with these medications, but it's different for each person. Okay. There's so many to talk about. I can't possibly talk about them all. The rashes, Stevens-Johnson syndrome, rare but can happen. Insomnia, weight changes. People are talking about all of these things in, online. But again, they're reported. They're uncommon. You know, talk to your doctor. We'll try to work around them. You should not sacrifice your life from side effects. We'll try to switch your medications if that's what's going on. Positive thoughts. Okay, so finding the right medication combination may take some time, but a large number of people are seizure-free on medications, and the majority have improvement in their seizures. And then all these alternative therapies are emerging. If you are refractory to 2 medications, talk to your doctor about other. That's when we start to look at surgeries and vagal nerve stimulators and therapeutic diets, and this is when we really have to, think outside the box, because if you're having a lot of side effects, if 2 medications aren't working for you, speak to your doctor. Okay, again, this is our mantra, right? No seizures, no side effects. All the epileptologists, neurologists try to live by this. Just because there's a reported side effect doesn't mean you're going to have it. Please learn all these information through validated sources, not through the epilepsy blogs. The Epilepsy Foundation, the doctors, the NIH, and again, find a physician you could speak freely with. Last thing is, I think this is the last thing, epilepsy and driving. My license has been revoked. My doctor said don't drive. You could hurt somebody. I feel like I have no freedom. Every state is different. you live in Pennsylvania, I live in New Jersey. Both have mandatory reporting, which we're not very happy with. And both require a 6-month seizure freedom period, but Pennsylvania has some exceptions. Most of us are very against mandatory physician reporting because you should feel free to tell me that you've had a seizure. And so are all the major medical organizations. The Epilepsy Society, the American Medical Association, we don't like this mandatory reporting, and we're fighting it. So your special considerations, if you have seizures strictly at night or immediately after you wake up, and that's been proven for 2 years, you can drive. If you have a prolonged aura that will allow you to pull over to the side of the road, and that's been a pattern for 2 years, you can drive. If your seizures were well controlled and you wanted to try to come off your medications, your doctor's taking you off, or you're changing your medication and you had a seizure, if you get back on your original dose, you could drive. If something else happens, if you...
I'll speak loud.
Yeah.
Are you saying that you can drive if, say, you only had a seizure at night, ever? Then they won't suspend your license if you actually report it? Because I know most people don't.
So you're asking that if you've had one nighttime seizure, you could still drive? Is that what you're saying?
Yes, that's the question. If you've only ever had major seizures at night.
If that's been the pattern established for 2 years.
Okay.
In Pennsylvania.
Okay. I had one last question. Well, I got the mic anyway. Like, say you know you're going to have a seizure and you're on a certain dose of pill. If you take an extra half pill that night, would that help at all or not really?
No, I mean, I would not recommend that because it's almost like a way to self-medicate without a proven effect. You know, as I said, we have these medications that we know take immediate effect. They're the rescue medications that we use if somebody is having a seizure. You know, if I take half a pill, if I take a pill, what's going to control my seizures? I don't know.
Let's say basically you always take a pill with dinner and you know you're going to have a seizure that night. Should you take a pill and a half or not really? They're saying they don't recommend that.
No, I wouldn't recommend that. I would recommend talking to your doctor about a rescue medication.
Okay. Thank you.
Unless that's something that you've established with your physician. Okay. All right. What can you do about the driving? You know, you have to be honest with your doctor because, you know, even though we are mandated to report these things, you're more at risk when you have seizures, and we need to change your medications. We need to alter something. Be honest with us. Be honest with the DMV. If you're not and you have a seizure and you're driving, it's big trouble. And then avoid driving in situations where you think you may have lowered your seizure threshold, if you drank too much, if you stayed up too much, you know, if you're sleep deprived. And that is it. Any questions?
Oh, you go first. Rock, paper, scissors? Go. All right. I do have a question. Why are you so against the mandatory thing? If you know it's going to save lives on the road, why is it such a big issue to have?
Well, we're not against the fact that you shouldn't be driving. We're certainly aware
I totally
that you shouldn't be driving. The fact of the matter is, we shouldn't be we're not police officers. Mm-hmm. And we're afraid that if you know that I'm going to report you, you're not going to tell me about your seizure, which happens all the time. And if you don't tell me about your seizure, I can't help you.
Gotcha. That's totally understandable.
I just had a question. When you were talking about pregnancy, you talked about folic acid.
Yes.
Is that recommended just for pregnant women, or is that for anyone?
Just for pregnant women. Or
Okay.
planning to be pregnant.
What's that?
Or planning on getting pregnant.
Thank you.
You just answered my first question about the folic acid. My other question is, when you keep saying rescue medications, are you talking about the Ativan and the diazepam
Yes.
that you would take? As that gentleman said, if he thinks he's going to have a seizure, take that? Mm-hmm. Okay, thank you.
Anybody else?
Thank you. Yeah, I just had a question on special considerations. There's time limits of 2 years for certain situations, but then if you're previously well controlled but a seizure occurred during a transient illness, so is that a gray area? Like, okay, my daughter's been good for 8 months and then she, had mono or something and then she suddenly had it, or she had the flu and she suddenly had a seizure.
Yeah, these driving laws are all a big gray area and up to interpretation.
So it's case by case, basically?
Mm-hmm.
I did have one other one, sorry. Has there been any research, maybe I'm sure there probably has, that I haven't heard of? Certain people have a warning sign, physiological changes that let them know that something's coming, and others don't. Has there been any tie to figure out why some do and why some don't, and ways that they can get that early warning system if they don't already have it?
Yeah, so those warnings that we're calling auras, right, are actually simple seizures. Okay, they're considered small seizures in the brain. So if you're having these simple seizures for a significant period of time that you're able to understand what's going on and that's consistent, then you're going to have an aura. Whereas if you're just having something that spreads very quickly and you don't have that small little focal area lasting for a good period of time, then you're not going to have an aura.
And there's no chance of developing that, or I know they have like the dogs that maybe can sense it if you don't, or at least there's some thought to that anyway.
Yeah, I can't really tell you how that works, to be the dog thing, to be 100% honest. But yeah, we know these changes are going on in your body, right? So is there a way to enhance the understanding of what's going on in your body, maybe through biofeedback? I haven't heard of that happening.
Okay, thanks.
Let's say if you just had a major seizure, you wake up, you're with somebody, what's the first thing they should do?
So if the seizure was short,
No, let's say it was a big one and you're with your spouse or significant other. What does your spouse do first? Once you regain consciousness, or?
Right. Well, if it's a prolonged seizure,
Yeah.
she or he should call the ambulance.
Let's say she doesn't do that. What should she do next? Not funny. Not funny. It's the license issue.
Which is why you don't tell us. Well, considering she probably did all the stuff she should be doing while you're having the seizure, making sure your neck is free of any, ties, put you on your side, and you woke up, and you're feeling okay, you didn't hit your head, you didn't have any traumatic brain injury, you're in a comfortable position, all I would say is inform your doctor. Let you rest and inform your doctor. If it's a short seizure. If it's a long seizure, you should go to the hospital.
Okay. One more question. I had that sleep test where you go to sleep, they test it. I got 3 different opinions. One doctor said that's not a seizure. One doctor said it was. And my doctor said, well, it's activity of a seizure. So is there any more correct way to judge something like that? Basically I got 3 opinions from 3 different doctors at the same hospital, this one. So, is there any, I don't know, I guess I thought, well, okay, that's true. If we could go for a 4th, but is there any?
This was a sleep-deprived EEG is what you're saying?
No, it was sleep, when you go to sleep for 6 hours, they put the things in your head.
Oh, it was a long-term
Yes.
EEG. And this was an you saw the epileptologist?
I guess so, whoever's, yeah.
Yeah, I would just make sure that who you're speaking to is an epileptologist, and if they think that you're having seizure activity, then you need to be treated for it. That would be the best interpretation I would have.
Okay.
If one person said it wasn't a seizure, then maybe they should talk to each other.
Okay. And I'm sorry, gang, this is absolutely the last question. Is there anything you can do at all? They gave me a list. There must have been 150 things on there. Don't have caffeine, don't do this. Is there anything they found specifically that would help prevent a seizure? Like exercise, not exercise, too much sunlight? Is there any 1 or 2 things they could say, hey, this will really help for sure? The list they gave me went from here to this guy over here. It was no stress, too much sleep, not enough sleep. It was almost anything.
if there was something like that, we would tell everybody. It would be this miracle. Don't
So it just
eat
varies.
fish, and all of a sudden you're not having seizures. We know the basic seizure mechanisms that will, trigger a seizure. As the list is this long, right? You just said it. Sleep deprivation, stress, whatever. But some people do have specific triggers based on their epilepsy type. So some people have the photics, the sunlight coming through the window, and they'll have a seizure. And they have certain, tinted windows or glasses you can wear. It depends on your seizure type.
I've only ever had a seizure at night, and I work on ladders all day. Is it pretty much going to stay that way? You think I'll always have them at night?
If your doctor thinks you have nocturnal epilepsy, the majority of people remain nocturnal.
All right. That was the last one. Sorry.
This is all new to me. My daughter's 24. She has cerebral palsy. She's only had 2 seizures, one in July and one before Christmas. She is now on 30 milligram of phenobarbital at night and in the morning. I was wondering, this is all new happening, and I'm kind of jotting things down to try to see, like when she gets her period and stuff, and I'm finding that, and maybe somebody else could tell me if they've noticed this with themselves or their child, that around her period time, now she hasn't had a seizure, but I'm noticing she's sitting there and I talk to her and I ask her a question, she kind of like is not answering me, she's drifting, and then I'll say, Kaylee, are you okay? Did you hear what Mom said? And she won't answer me, and then in a little while then she will, and she seems okay, a little slower, but then okay, and then gets okay. Then she's fine. Are these mini seizures?
It's possible. It's definitely possible. It's definitely something you should talk with.
And I did, but because this.
Yeah, it's definitely.
This came before her appointment.
Oh, I see.
I thought, well, this is good. I can come and ask questions, and there's so many women here that maybe have children or
we
have
do know
seizures
that
if you find around your period time. I'm finding that some people do have hormonal seizures. So this is new to me, and I'm here because, I don't know, and I'm trying to educate myself on it. So has any other women seen that with their children or themselves, that they found that things happen to them around then?
Well, we do know that there is something called catamenial epilepsy, which is where someone will have seizures around the time of either right before their menstrual cycle or, right after, and that's based on the hormone levels, mostly the drop of progesterone. What your doctor will probably recommend is to keep a calendar. Some people will even ask to take ovulation tests, to mark periods of ovulation, because there are other types of therapies for people with catamenial epilepsy.
I'm finding that that's where I'm seeing this drifting, this, losing her for a couple seconds to a minute, like here and there. And it's happening about 2 weeks out of the month. Not every day, but so this is something normal. Has anybody else experienced this?
The same ones I get are still the guy in the hall. He would ask me a question, and I just can't answer. I'm kind of stuttering and smacking my lips. And that's like 10 or 20 seconds. So maybe she has the same thing, if she's just not in.
Or a partial complex seizure. It could be either, yeah.
Gynecologist and stuff to do hormone levels and stuff, because I've been documenting this. Do they normally just increase the seizure medicine, or just, I would think, try to get a hold of the hormones and get them regulated? Or
sometimes they'll increase the seizure medication. Sometimes they add like a progesterone, depending on how well documented the cycle is. There are other medications like Diamox that some people use for catamenial epilepsy. They are a little bit different sometimes. So they do have modifications.
Okay, thank you.
I think we have time for one more question.
Sorry. Hi. So when you were talking about prolonged seizures, if your seizure symptoms last maybe 2 to 3 minutes, but you're taking a really long time to become responsive, you're extremely lethargic, you might come out of that non-responsive stage, or I shouldn't say, you'll come out of maybe the unconscious element, but you're still not responding, but you can recall what everyone around you is doing or saying, is that considered a prolonged seizure, or is that?
No, I mean,
Okay.
it kind of gets a little tricky because people can have these non-convulsive, seizures after the seizure, but for the most part, that's called the post-ictal phase, the
Okay.
after the seizure phase, because your brain's firing so fast, so erratically, it kind of just like depresses and gets very fatigued, and that's not considered part of the seizure. That's the recovery phase.
Okay. Now, with that, is that something that, I mean, essentially, does that ever, will every seizure, basically, if that's what it's all different, you just don't know, right? Like how long the recovery after, if your pattern has been that this recovery takes sometimes 3-4 hours to feel back, whereas other people might say hey, I have it and I'm up and I'm going and things are great.
Yeah, it could change. It depends on the length of the seizure also.
Okay, thank you.
Sure.
Sorry.
Okay. All right.
Thank you, Dr. Palangio. I just want to mention there's a Viennese concert and ball on April 19th in Pottstown, Pennsylvania. If you're interested in this, it's to raise fund for epilepsy, specifically the foundation. If you want more information about it, I believe we have some flyers. If you could fill out those forms, you can leave them where you're at, or you can leave them at the table as you're leaving, the evaluations. I'd really appreciate it. Have a wonderful night. It's raining out there, I believe. Happy spring, and thanks for coming. I love your purple. You're wonderful. I love that.